Hey!
Success. All right, chapter 34, multi-system trauma. You'll be happy to know that this chapter is not very long. Then we're going to get straight into the practicals.
So I better not eat. If we do the helmet thingy, y'all need to be real careful with squeezing my little mouth because my wisdom teeth hurt real bad. Jim didn't know that, and he grabbed right a hold of my face, and I was like,
Listen, after my display earlier, I should be wearing a fucking helmet right now.
Okay, so multi-system trauma, multiple trauma patient, which means they have more than one serious injury, not more than one patient specifically, right?
Yes.
One or more injuries serious enough to affect more than one body system. Hear what I mean? Not what I say. So, I mean, it could be. What's a 22 round going to do? Bounce around in there and meh. So you could, for sure. Teamwork, timing, and transport decision are key in proper management.
Do they bounce around so bad just because they're so little?
That's your homework. Got it.
So go through some of the 22.
No, that's not what I meant. Oh my gosh. Most critical decisions. What's your patient priority? What's the severity? Yeah. Whether to limit the scene time or not, and which hospital or transport method is best for your patient. Yeah, here you're getting one of two things. If it's around Douglas, you're either getting MHCC or you're getting flight. We're not city bound to where you've got Sunrise Hospital on Las Vegas Boulevard or you've got Kindred on Flamingo. Like you just don't have those kinds of choices. Sunrise isn't on Las Vegas Boulevard, but it is downtown. Okay, all right. Does your patient have an altered mental status? Head injury? Are they going into shock? Where's the injury at? So if they have an injury in their pelvis and they're bleeding internally, is that like load and go or stay in play?
Load and go.
We go. Abnormal respiratory rates. Remember last week when we talked about Chain Stokes and biots and all of the things? An amputation proximal to the wrist or ankle. If they're not bleeding out of an amputation at the wrist or ankle, what's happening?
Shock.
What else is happening? If they have an amputation at the wrist or the ankle and there's no blood coming out, what might be happening? That blood's going somewhere else, right?
Yeah.
So there's an internal injury somewhere, and so it's trying to protect your core because that's the most important part of what your body and your brain say needs to happen, right? Pelvic fractures, open or depressed skull fracture, and paralysis. Anatomic criteria, penetrating injuries to your head, neck, torso, and extremities, proximal to the elbow and knee. Is the chest wall instability or deformity?
Like
Flail chest. That was a bad day. All those things are just bad days. 2 or more proximal long bone fractures. Crushed, degloved, mangled, or pulseless extremity. In absence of anatomic or physiologic signs, MOI is considered if severe. So what's our fall criteria for an adult? Yep. High risk auto crash, intrusion, ejection, death in same passenger compartment, and vehicle telemetry data consistent with high risk of injury. What about motorcycles? You're going to get the potential for bilateral femur fractures on a bicycle or motorcycle if you get in an accident? Because if you go over the handlebars, what are your legs gonna hit? Handlebars, or they're gonna hit the vehicle. So you could very well have some really good leg injuries. Sorry, wrong button. Older adults do not efficiently compensate for shock. Children may benefit by transport to a pediatric specialty facility. Again, if we're out in the Boone Tulies, we're calling flight. JJ and I have been on a call where 3 helicopters have shown up for one accident. So we're going to get everybody we can, so that, especially if we know that those patients need to be higher level of care. Patients with certain conditions taking any anticoagulants, or if they're pregnant. A lot of this stuff is kind of like JJ and I were talking earlier, a little bit repetitive. Trauma is trauma. It's just where is the trauma that's different, right? Managing of your patient. When do you recognize that the patient has multiple injuries? What body systems would you suspect have been affected? Absolutely. Yep. What is your first decision about managing these injuries, and why would you make it? Right, life over limb, right? What? Severity, sure. What actions would you take to support the affected body system? So let's say it's femur. That's a long bone. Okay.
If you're losing a lot of blood.
Okay. Splint. Yep. Is it open? Is it closed? All of those things are going to factor in, right? And if it was a femur or a pelvis or anything torso related, load and go. Yeah. If you can.
That we talked about a little bit earlier when we were watching the video. Why would you not even just like throw something over like loose things so that stop other stuff from doing it? There's like in the video, Kings was lost at above knee, and then they just like tourniquet, sandwich board, backboard, dipped.
So we just discussed life over limb, right? You're not wrong. Do you have time? That video wanted to show you the importance of the steps to take in order to go. Would you? Probably. I mean, you want to keep your eye on it, right? You don't want to occlude it to where you can't see what's happening. You want to make sure your tourniquet continues to work once you've moved that patient. Is it slippery? Did the tourniquet slip? Is he bleeding out again? So I would imagine that that's why they didn't cover it up, so that they can still assess that wound.
I would just be terrified to like add stuff and like get injury.
Right. But I mean, he's already lost his leg, right?
That's fair.
It's already gone. The chances of it being infected is already great. That dude was laying on the ground on the pavement. Pavement's nasty. So it's already gross. I mean, I get what you're saying. We live here, we're gonna get dirt and grass and sage and all the things.
Tumbleweed.
Yeah.
So
Goat
you should
heads.
cleanse the bathroom right after that.
We tried, sir. We tried. So yeah, but I would imagine that's why. But I mean, if you have time,
Yeah.
you're also gonna cover him to keep him warm.
Right.
Use what you got. Yeah.
I just didn't know if it would be like a bad thing.
I would say as long as you can still assess that injury, you're going to do what you feel is best for your patient in that scenario, because every scenario is going to be different.
You're not actually going to make it worse if you don't. The germs that are in there are in there.
They're already in
The fight for infection is going to be the fight for infection either way.
Yeah.
You're not going to prevent it from being worse by covering it.
Yeah, I was thinking more less infection and more like the dirt and the
gross, like.
Yeah,
you have to,
and
like, scrub out
I mean,
the-
depending on how that person amputated that body part, it may have to be even cut back further once they get to surgery in order to make it to where it heals properly too. So
That's fair.
everything you're worried about getting dirt in it
I didn't even.
is
think
either
about
gonna
that.
get cleaned up and it's fine, or maybe they're gonna have to take more and it ain't gonna matter anyway. So using that video shows an example of a patient who had a critical injury, which for those listening in, that critical injury was a left leg amputation at the knee, above the knee.
I thought it was so.
Either way, left leg amputation.
It was like, I thought it was like here, and
Like,
it's like mangled.
Yeah, the bottom half of his leg was about 10 feet away from him. Primary assessment revealed several immediate life threats. What did they do first? Stop the bleed, right? You realize the seriousness of the patient's condition, and did you delay transport? I know that you feel in the video they did, but that video was literally only 5 minutes long, so technically,
Yeah.
not really. But all in all, a good judgment call how they did it.
They were just
They
very
stopped the
encouraging.
bleeding. They did the tourniquet.
Ian felt like it was longer than it was. 'Cause he stopped listening to the damn bird.
And they did a
Not even
load and go,
real.
right? So stop the bleed, tourniquet, splint, load and go. Not a bad gig. Determine roles for multi-system trauma patient beforehand. Using the call that JJ and I were on together, there was 4 of us, 6 of us. There was 6 of us total eventually, plus fire. 18. 3 ambulances, 3 helicopters. We all had a job. We all made sure that we were doing delegating, and when we got done with one job, we went and double checked with the IC, and we made sure we had another job if we didn't have one to do. Right? Always going to be talking to your incident commander. Follow priorities determined by primary assessment. And remember the golden hour. The golden hour has been taught for hundreds of years, if you will. Need for critical trauma patients to get surgery within the first hour of injury, not the hour from when you get to the patient. So if it happens at 10:30 and you get there at 11, you're going to hope to heck you've got time to get back by 11:30. Get them in surgery, get go. That's the goal, for example. Hard to do in a rural community sometimes. Limit your scene treatment if possible. Again, if you're big cities have the issue of traffic, we have the issue of distance. It's just how it is. Stabilize your cervical spine. Suction your airway. Insert oral or nasal. Restore patient airway. Ventilate. Administer high O2. Control bleeding. And respect me. Restrict spinal motion. What practical sheet does that remind you of? I mean, you're not wrong, but you guys actually have been doing a station already that is very much in that order. Bag valve mask. Good job. Paying attention. Scene safety is paramount. Ensure your open airway, perform urgent or emergency moves as necessary, and adapt to the situation. We're going to do that on every call anyways. Right? Your pediatric patients will need additional emotional support. They're not going to understand a lot of times what's happening. A 4-year-old going to be able to figure out why their mom is not next to them and now there's a stranger treating them. And when deciding whether whether spinal motion restriction is necessary, Many protocols add consideration of MOI. If your littles are in a car seat when the crash happens and you suspect an injury, where do you think the best place is for your little? Leave them in the car seat. Because if you jostle them around and lay them around and whatever, I mean, it's too bad that EMTs and paramedics don't have x-ray vision, because that sure would save a lot of questions in the field. All right. All right. So now do you guys have any questions so far about any of that? We're going to start getting into the trauma scoring. So that's it's in your book. It's going to be on the left-hand side, or the right-hand side, I mean. Closer towards the end of the chapter, I believe. It's not a very big chapter, so. And then I also printed,
Page 1009.
page 1009. I also printed you one that's shaped a little bit different on your good stuff. So the revised trauma score, your components, GCS, which we talked about last week, systolic blood pressure and respiratory rate. Follow the local protocols for use in the trauma scoring system, and don't let it interfere with patient care. Here's that picture blown up. Casey might want to take a picture of it. Not you, Casey, him, Casey.
I'm in that.
Glen Rock Casey, not Douglas Casey.
Casey with one E.
Casey with one E, true facts. Okay. All right. So this is just the appendix. Basically, so you can see how it's broke downish. I thought you were raising your hand. I was like, yeah, babe, what's up? No, you're fine. You fine. Casey, on the video, I will send you a link to watch a breakdown of this trauma score.
10-4, thank you.
You, Hakeem. All right.
This was the least painful class I think we've ever had.
I told you it was quick.
Not mentally painful, but physically painful.
Oh, yeah. He whacked his noggy, bit his tongue. His whole vibe.
That's your own fault. That's
Right. I'm just gonna let these videos up so Casey can read them really fast. Because otherwise, Casey, we're pretty much done with this class. It's just chapter reviews now. DED. Your primary assessment should determine whether your patient is seriously injured or potentially seriously injured. Limit your scene time.
So it's like seriously injured, be like, oh, his leg is gone now.
We go.
Potentially injured would be like, done something to this.
Well, it's a
Is that
scene
what that
assessment,
is?
right? So that'd be like, you either see the patient on the ground bleeding profusely or the mechanism of injury as we're coming up to the scene would indicate that there's a possibility for a serious injury.
Yeah. So case in point, to touch on Ian's thought process here. We went to a accident at the 147-ish northbound. There's a bridge deck there. Little tiny red car, mangled front to back. Didn't roll, but he had spun around enough and hit the guardrail enough that he was pretty mangled. by looking at the car, you would think that that gentleman should be so broken. He literally had a cut to his lip. That was it.
What kind of car was it?
Little tiny, like almost made you feel like it was a Datsun 210. That's how tiny it was. Just a little tiny, yeah, like the green Taurus that I used to drive. Very much like that, just little. Cut to his lip. The only reason why is because he fell asleep. So when he started wrecking, his body was in limp mode. Had he been awake and tensed up, who knows how he would have ended up. But that's just the kind of stuff like looking at the car. You're like, oh dang, this bad day. No, dude was out walking around, cut to his lip. But you're gonna look at the scene and you're gonna just automatically assume the worst, because then when you get there and you don't have the worst, you can be like, whew, yeah, that's a good day.
You know what scene? There's another car wreck.
Hey, hold please. Hold that thought. Hold the thought. All right, Casey Blaylock. Short, sweet, and to the point.
Okay, thank you. I appreciate it.
You're welcome. I'll put your name in the book.
Okay, thank you.
Okay, good night.
Good night.